Hi everyone, thanks for listening to my presentations. Today I'll be talking about dyspepsia treatment and diagnosis. I have published earlier dyspepsia definition, symptoms and causes, and also another one on H-pylori testing. You can check my channel for both. Okay, let's go. To make a diagnosis of dyspepsia, we need to have a thorough history and physical examination. With that, we'll be able to identify alarm features, which will include unintentional weight loss, probably also including dysphagia, which is difficulty swallowing. There can be odynophagia, which is painful swallowing, iron deficiency anemia, persistent vomiting, lymphadenopathy, palpable mass, or positive family history of gastric ulcer or gastric carcinoma. If you're able to pick any of these, we're going to make a referral appropriately immediately. Okay, if we have ruled out alarm causes, then we have to take history around other possible causes, including medications, ruling out all possible differentials. On physical examination, which will be usually normal, we can pick epigastric tenderness. Okay, that's possible. And there's what we call carnal sign. In that wise, there will be local tenderness that will be increased with muscle tension, and that will be suggestive of abdominal problem. But if the local tenderness decreases with muscle tension, then the pain is from internal organs called viscera. The palpable abdominal mass and lymphadenopathy, for example, if you pick left supraclavicular lymph node enlargement or periumbilical lymph node enlargement, that might be pointing to gastric carcinoma. We can then employ the services of those good people working at the labs. Complete blood count with differentials, liver function test, renal function test, lipase and amylase, because pancreatitis or pancreatic carcinoma could be involved here, blood glucose, H. pylori. I will not waste your time here going over H. pylori testing because there is a separate presentation on H. pylori testing already published, so check my channel for that. You can have radiological investigation done, like X-ray and endoscopy in anyone greater than 60 years, endoscopy with biopsy if you're suspecting H. pylori. Even endoscopy is compulsory in everyone with alarm features. Upper gastrointestinal variant study could be done if in your center you don't have endoscopy. You may embark on CT scan if you are suspecting pancreatic carcinoma or pancreatitis. And of course, gastric emptying studies could be done, but not usually done. Okay. Okay. We have taken the history, we've made definitive diagnosis whether it's functional or not, and we want to start intervention. The first thing to do is pieces of advice under the umbrella of non-pharmacological approach. Okay, so if the history has revealed that non-steroidal anti-inflammatory drugs usage is involved here, stop it. But if non-steroidal anti-inflammatory drugs must be used, like in the case of aspirin, in a man with post-myocardial infarction, then proton pump inhibitor must be prescribed along, must be given to be taken ahead of the aspirin. Okay? Decrease fasting. Decrease fasting. Have something to buffer the acids. So eat small meals, right? So something to mop the acid. Remember, I've said when there is empty stomach with high level of hydrochloric acid secreted, that will beat the duodenum as well. Reduce coffee. Oh, my friend is mad at me right now. Why are you talking? Well, for your own good. Okay. Minimal orange juice intake. There's a particular combination here that I will talk about in a bit. No spicy foods. Oh, another friend is mad. No fatty meals, please, or at least reduce to the barest minimum. You know what I'm talking about? Frequent small meals is better than a very heavy large meal, and eat slowly. No gulping of food, please. No one is going to steal your food from you, okay? And rest after. Oh, now, this is the small arrangement I wanted to put here. Somebody eats large meal and eats very quickly and gulp a lot of coffee after, or 2 bottles of pop, and few minutes or few hours later is complaining to me, I have indigestion and so on. Why not? Why won't you? So change the lifestyle, and you're likely going to enjoy yourself without using any medication. Because most of the times, the diagnosis in 75% of people is functional. No definitive cause or causes. If the age is greater than 60, you have to have endoscopy done, and with biopsy. If no organic cause is identified, then the diagnosis here will be functional dyspepsia. If an organic cause is identified, we are going to treat that cause. Okay? Then that will take us to lab. We will do H-pylori testing and publish that. Okay? So is H-pylori present? If the answer is yes, then we can start with triple therapy. That will involve proton pump inhibitors like omeprazole, clarithromycin, and amoxicillin. It is either HP pack or Losec 123A or Nezin 123A. If allergic to penicillin, we can use proton pump inhibitors, clarithromycin, and metronidazole as Losec 123M. You may choose quadruple therapy involving proton pump inhibitor, bismuth subsalicylate, metronidazole, and tetracycline. But not everyone could take tetracycline, remember? Note this. After you have successfully eradicated H. pylori, there is that possibility or probability of reinfection. Therefore, you have to perform urea breath test, stool antigen if it is active, or endoscopy, of course, which is the gold standard, with biopsy to confirm H. pylori. I am not suggesting serology here because it's not that useful at this stage, because if you listen to my presentation on H. pylori testing already published on my channel, you will get a clearer picture. But let me give you a hint here about that. Serology for H. pylori after you have successfully eradicated H. pylori could still be positive. So that's why I'm not suggesting that. Continue proton pump inhibitor if you encounter complications like perforated peptic ulcer. There's peptic ulcer disease, the intestine is already perforated. Please continue proton pump inhibitor while you invite the surgeon for intervention. If you encounter bleeding, continue proton pump inhibitor. If you are dealing with severe symptoms, continue using proton pump inhibitors. Continue the proton pump inhibitor until H. pylori is eradicated. So that is one drug that we may use for a very, very long time. difficult H. pylori. When we are faced with recalcitrant peptic ulcer disease, because the H. pylori is difficult to eradicate, we can use Losec 20 mg twice daily with bismuth salicylate 2 times QID, metronidazole 250 mg QID, tetracycline 500 mg QID, all per oral. You can replace metronidazole with amoxicillin, and you might replace tetracycline with clarithromycin. You know the reason, right? If someone is allergic, if someone could not take tetracycline, maybe because of the age, you replace appropriately. Okay, in addition to H. pylori eradication regimen, you can also use prokinetic agents like metoclopramide, domperidone. Remember, I have said nausea and vomiting as part of symptoms before now. Then you want to increase gastrointestinal or peristalsis so as to reduce that to a certain extent. You can also use antidepressant because of the pain using amitriptyline, desipramine, or nortriptyline. But be careful, don't go for high dosage because of the effects on the cardiovascular system. Nortriptyline is actually better if you are dealing with elderly people. If peptic ulcer disease is secondary to the use of aspirin or non-steroid anti-inflammatory drugs except celecoxib, then first thing first, stop the medication. After stopping the medication, what next? Give proton pump inhibitor, Losec, meprazole, Nexium, esomeprazole. Give H2 antagonists, cimetidine, ranitidine, Zantac, Tagamet, Pepsi. And they give misoprostol. Misoprostol, that is prostaglandin analog. Very, very good. Now, when it comes to NSAIDs and peptic ulcer disease. Okay, if this is a situation where we cannot just stop the medication, maybe for prophylactic purpose, then we use low dose and give proton pump inhibitor. You may continue with that low dose of your aspirin. Particularly, this is myocardial infarction and post emergency room, and you are preventing future occurrence and must be on aspirin. Then give low dose and give proton pump inhibitors. We have to test for H. pylori and treat appropriately. Prevention of peptic ulcer disease. A patient must be on aspirin, an NSAID or steroids, alendronate, antiplatelet, selective serotonin uptake inhibitors or anticoagulants per oral for a long time. Then use what? PPI, proton pump inhibitor, once daily. Give misoprostol 200 micrograms 4 times daily while you are administering the said medication listed above. This is necessary if the patient is greater than 50 years old and have some comorbidities. That is, there is nothing you can do. For example, this is maybe 55 or 60-year-old woman and menopausal problems, and you need to give your steroid and alendronate, then you have to give. Or this is a 60 or 70-year-old man with cardiovascular problem, ischemic heart disease, and you have to give your antiplatelets. And even somebody having DVT, and you have to give your anticoagulant, then you give PPI and misoprostol, prostaglandin analog. Celecoxib has less gastrointestinal ulcerative effect. That's good, right? To be used if you are dealing with rheumatoid arthritis and you need to prescribe non-steroidal anti-inflammatory drugs and there's dyspepsia or there's peptic ulcer, right? But what are you going to say when it comes to cardiovascular complications? Discuss with your pharmacist or discuss with any other colleagues that, two heads are better than one, right? But it's good. Celecoxib is good under this situation when we are thinking about non-steroidal anti-inflammatory drugs and peptic ulcer disease problem. But I will not be lazy to forget to tell you that watch out, cardiovascular complications on the way. You can choose from a list: omeprazole, pantoprazole, Tecta, that is pantoprazole with magnesium, lansoprazole peravazid, pantoprazole sodium pantoloc, rabeprazole parate, esomeprazole nesium, misoprostol, ranitidine Zantac, cimetidine pepsid or Tagmate, nizatidine acid. I need to declare here that I'm not an agent of any of the pharmaceutical companies selling any of these drugs. No, I'm just presenting what is the appropriate medications to use under this situation. You can also choose from Diavol Plus, Gelusil, Gaviscon, Amoxil, metronidazole, clarithromycin, tetracycline, and bismuth of salicylate. Note: codeine will worsen dyspepsia. And with that, I've come to the end of this presentation. Remember to please share and subscribe. I'm wishing all affected people a quick relief and speedy recovery. Thanks, I appreciate it.